about the performance pay or tying payment to quality. Could you tell, in your studies, you've obviously studied this a lot, can you tell me your views on that and some of the pitfalls you see and or the challenges? I know you said it was in the infancy stage, but just what your experience has been or how you view that?
We have a wonderful medical profession in this country, wonderful hospitals, wonderful doctors, the best in the world. And Pennsylvania really, in teaching hospitals, leads the way. But you've got to motivate the system to change. Think about it for a second. Why are there $4 billion worth of hospital-acquired infections? Why are there? Don't the hospitals care about the quality of care that they deliver? Aren't they worried about what happens? By the way, that $4 billion, also 2,500 deaths a year. 22,000 cases of hospital-acquired infection, 2,500 deaths. And the interesting thing, all the cost containment stuff I talked about, better way of handling chronic care, hospital-acquired infections, medical errors, all those things improve the quality of the system. Normally when we save money, I know when you try to save money in Washington, people say, oh, you're hurting people. Here, we're saving money and helping the quality of the delivery of the system. So preventable medical errors are step one, and we're doing it in the Medicaid program. We intend to do it for everyone in our system, for our seniors, for our employees. I mean, we are the 800-pound gorilla. The state of Pennsylvania actually insures 24% of the people who get health insurance in the Commonwealth of Pennsylvania. So we intend to do it, and I'm talking to employer groups about doing it. Why? Because it will motivate cost-saving and quality-inducing changes that we can't seem to motivate anyway. When I visited the Pittsburgh Veterans Administration Hospital, and if you all have time, go there and see what they've done. What the protocol is neat and it makes sense, but the thing that's so important is everybody has bought in. The doctors, the nurses, the janitors, the maintenance men. We had a janitor who showed us with great pride his storage room, and he said, Governor, I don't leave work until I make sure there are enough caps and gowns and masks in here so nobody can use as an excuse that they didn't have available caps and masks and gowns. Everybody's bought in. And right now, the medical profession isn't thinking about cost savings. At some of our great teaching hospitals, I've had people tell me that surgeons look at hospital-acquired infections as a cost of doing business. Well, we've got to motivate them to start thinking about quality of care and about cost reductions.
Thank you. I'd yield back.
Ms. Feinman.
Thank you, Governor, for coming today. I was just slipping out to another meeting, but they told me I was next to ask a question, so I'm going to stay for just a second. I was interested in your comment about the 2 men and the 2 women, and the 2 men left and the 2 women were hired, and the insurance premiums went up for the small business, if I remember the story right. And you were talking about how the women are of childbearing age, and so the rates went up because they were rated differently, and how we got to resolve the difference on ratings in various states. And, as I was sitting there thinking about that, Mr. Chairman, I was thinking about how women are kind of discriminated against with their ratings on health care and health care costs for insurance, and how, I could see where employers might rather hire a man than a woman if their insurance premiums are going to go up because a woman's of childbearing age. So I just thought that comment was kind of interesting. I hadn't really thought about that in the past.
It's devastating. The smaller number of employees you have, the smaller your pool is. Demographic rating allows them to rate just your pool of employees. Community rating is you rate all of the people in that HMO in the entire state or in the entire nation. We should basically have community rating with a few nods. Obviously, age would be one. The geography would be one, because in certain parts of the country, in Philadelphia, it's more expensive to have health care than it is in Tioga County in the northern tier of Pennsylvania. So some limited number of factors in which they can spike rates. But again, we want to reduce the spike to no more than 2 to 1. Right now, some rates spike 7, 8 to 1. Heaven forbid you've got 5 employees and you want to hire this brilliant woman who's got a brilliant resume. She's 39 years of age, and in her mid-30s, she successfully fought breast cancer. Wait till you see in states that have demographic rating, wait till you see what happens to that small business's overall premium, because they've hired somebody, even though the breast cancer is in remission, who's had breast cancer. So, yeah, I think there's a lot of discrimination in the system as long as you allow demographic rating.
I appreciate your comments. Thank you.
Ms. Clarke?
Thank you, Madam Chair, and thank you, Governor. Why is it that you think that only certain small businesses get access to the subsidized health plans under the CAP program, and why not all small businesses?
Well, because let's say you're a hedge fund, and you have 20 employees, and the non-administrative employees, let's say the 12 professional employees are making, on an average, what the hedge fund these days, $3 million each. We don't think the state should be subsidizing them. But we do offer, by regulation, we would make the HMOs offer the same plan to them at cost. At cost. It wouldn't be subsidized, but they could get it if they wanted it for $240 a month per employee. They probably wouldn't want it because they'd probably want a few things, like, for example, only dental emergencies are in Coverall, Pennsylvanians. Now, a hedge fund is not going to want that plan, obviously. But that's why we did it, just to make sure that those firms who really can't afford to do a non-subsidized plan take it.
Mr. Buchanan?